Today I'll talk, my talk is short and precise. My aim is to answer the question what to use in imaging of Crohn's disease, either to choose MR enterography or CT enterography. That's a question that always needs to be answered, so I hope by the end of this talk we can be able to choose which one to start with. Cross-sectional imaging for small bowel is the current state-of-the-art imaging of the small bowel. It allows visualization of the whole bowel loops with no overlap and helps in detection of extra-abdominal pathological processes. There is now a global rising in the incidence of Crohn's disease. We don't have statistical incidence and prevalence in Egypt, but with the global rising, we expect to be rising in incidence and prevalence in Egypt. There are three techniques that we can do now: MR enterography, oral contrast media is administered orally, MR intercolysis, and this is less convenient to the patients because it's given through an nasogastric tube, so it's limited to certain indications, and CT enterography. Indications of enterography, either CE or MR. Crohn's disease is the primary indication, as many patients present at young age, require multiple follow-up, and also to detect complications. CT is done as a baseline study, then MR is used for follow-up. However, MR can be done at first. MR is done in cases where CT is contraindicated, as in patients where we cannot give the iodinated contrast media, in pregnant patients or in young children. Enterography is also done for screening of polyps in polyposis syndromes and evaluation of small bowel masses. Indications for MR entercolysis: low-grade intestinal obstruction, when we can't administer oral contrast media as a patient with continuous vomiting. It's preferred to MR enterography is preferred to entercolysis and is more comfortable to patients. CT enterography compared with MR enterography is technically more robust and easy, has short examination time, it's more accessible, there is high technical and interpretive reproducibility, it's better in evaluating clinically unsuspected pathology outside the bowel, it works better for acute, severe, complex, and emergent cases, it's less expensive, however, it causes radiation exposure. MR enterography compared with CT, technically more difficult, long examination time, less accessible, relatively lower technical and interpretive reproducibility, better suited for organ-specific and disease-specific as Crohn's disease evaluation, may not work well for acute, severe, complex, and emergent cases, and no radiation exposure. For Crohn's disease, both CT and MR are effective and essential. Neutral oral contrast is required. We do a single enteric phase, i.e. between arterial and portal venous phase. Contrast enhanced scan is recommended for CT enterography, and unenhanced and dynamic multi-phase contrast enhanced scans are recommended for MR enterography. Diagnosis based on imaging it's classified on basis of imaging to active inflammatory. There are no fistulas or stenosis. Penetrating disease where there is a complicated case where there is fistula or stenotic segment or even abscess formation. Fibrostenotic stage. Active disease, the most common thing we see are ulcers that are seen either superficial or deep fissuring ulcers. For the findings we find mucosal thickening more than 3 mm, submucosal edema, and this stage is usually managed medically. Here's a coronal image of the by MRI. Here we see there is thickening and hyper-enhancement, mucosal hyper-enhancement in the ileocecal region, and there is the dilated blood vessels going to the inflamed area. Studies have shown similar accuracy between CT enterography and MR enterography in diagnosing active bowel inflammation. This is another case of a CT where we can show dilated bowel loops and there is thickening and mucosal enhancement seen in the ileal region. Penetrating disease, this happens when a deep deep ulcer penetration occurs in sinus formation when a fistulous tract occurs bridging between the small bowel or colon, stomach, bladder, or the skin. Multiple abscess, and this usually needs intervention either surgically or by with the interventional procedures as putting a pigtail catheter or whatever the interventionists can do. In this case of MRI, where there is a fistulous tract seen here between the bladder and the bladder and the bowel, gives the fistulous tract that is depicted very clearly with the MRI. Abscess formation is also a common finding in the penetrating stage of the Crohn's disease. Here we see a CT image where we can find this is the abscess and this is the wall of the abscess. Is clearly depicted here by the CT contrast enhanced image. The third type of Crohn's disease that is detected clinically or by imaging is the fibrostenotic disease. This happens when active inflammation proceeds to fibrosis. It can lead to intestinal obstruction, which necessitates surgery. Here in this image, in this MR coronal image, we can see a long segment of fibrostenotic segment. That's the fibrosis appears as low signal intensity, and this leads to intestinal obstruction in this patient, where we can see like dilated bowel loops and dilated stomach. One of the tough questions is how to differentiate between fistula and adhesion, and usually the MR helps in answering this question. Adhesions between adjacent bowel loops can be distinguished from fistulas because adhesions are fibrotic and tend to be thinner and enhanced later than fistula. Therefore, when we do a dynamic imaging study, we can see later, at later phases, we can see enhancement in these tissues. Our fistulas are composed of vascular inflammatory tissue, so they tend to enhance early. Here is a coronal image, which this is an adhesion, so we can see a thinner band that is between the bowel loops, and it is low signal intensity image, so this is a fibrotic adhesion band. However, in case of fistulous tract, you can see the fistulous tract here, it is composed of inflammatory tissue, it shows enhancement and it's thickened because so we can differentiate by MR if this adhesion or a fistula. It's usually difficult by CT. This is also a stenotic segment seen by CT. Another finding that is usually detected by MRI if the patient has associated colitis. We can see mucosal hyperenhancement, the thickening of the colon, and the diffusion image help us to show the diffusion restriction, which means active inflammation. And to sum up, CT enterography is recommended for first enterography examination. CT enterography is recommended for acute, severe, complicated, or emergent cases. MR enterography is likely better for repeat follow-up examinations after medical therapy, given the lack of radiation exposure. MR enterography is also advised for younger patients or when pregnancy is a concern. MR enterography is also needed when concomitant evaluation of fistulas are needed. Conclusion: CT enterography and MR enterography are not a mere substitute of each other, but a knowledge-based choice of the proper examination should be made for each patient according to the clinical setting. Thank you.
Thank you, Dr. Ali, for your excellent and nice presentation. We postpone the question for the end of the session.